Top third diagnosis in video, pneumonia. Okay, what do we need to know about pneumonia? Okay, most important is the patient an antibiotic virgin or not? When was the last time the patient got an antibiotic? If it's more than 60 or 90 days, the patient can be considered antibiotic naive, or we can consider it a non-hospital acquired or non-healthcare acquired infection. So we're trying to go into non-healthcare acquired and healthcare acquired infections. No antibiotics. Yes, antibiotics. Or they came from where? Nursing home, home. If they came from a place that they were using antibiotics, they're considered a hospital acquired. So you need basically an antibiotic virgin for at least 90 days to consider them community acquired, okay? Or non-healthcare acquired. Once you're down that route, what are your two most common pathogens? Strep, H. flu, pneumococcus, the atypicals, chlamydia. So we could treat with levo by itself. Okay? We don't use Cipro anymore except for UTIs. You can use Doxy. It covers atypicals. Okay? And, oh, you're on camera, hurry up. Thank you. Should we say their names as they cross the camera?
We'll put it in the title.
What's the advantage of using Doxy over Levaquin? No QT prolongation. It's well tolerated. It's cheap. Okay? It's available. It's it's very well tolerated. And it works for other things like what? Travelers, diarrhea. You can use it for almost anything. That's an outpatient type thing. Okay? The other combination you see all the time is Cipro with ceftazidime. Well, all this is the combination of what levo covers. Now, azithromycin may prolong the QT. We have recent studies where maybe Duke does prolong it, but doesn't give you arrhythmias. Erythromycin, its long daddy or granddaddy, really gives you QT prolongation. We don't use it anymore because of the spectrum, and also has a lot of gastric irritability. But azithro has an anti-inflammatory effect. It's still not well understood, but patients do better. So I don't mind this compensation because it's a once a day oral and a once a day injected. Okay? The majority of people are going to fall here. And here is, in a community or a healthcare acquired infection, what are the only bacteria that are living in the hospital? The ones that are resistant to the antibiotics so they don't get killed. Right? Which ones are those? Pseudomonas, MRSA, gram negatives, ESBLs, extended spectrum beta lactamase. Okay? If you're worried about this, you gotta use a pen. If you're just worried about the belly, the pen will cover it. Okay? MRSA, automatically you're thinking Vanco. If it's sensitive to nafcillin and it's non-MRSA, no, it's an MSSA, you can switch over to nafcillin, it's better than Vanco. But otherwise, Vanco is going to get you all your gram-positives, your anaerobes, anything that has a capsule on it, enterococcus, all the anaerobes that you use. Say we have toxicity to the kidneys, so be careful when using it, especially in patients that are dehydrated. Make sure you get peak and trough levels. Okay? Pseudomonas, third, fourth generation cephalosporin, cefepime, or piptazo. You gotta cover the bad gram negatives, including Pseudomonas. If you really think Pseudomonas is the pure cause, or you get back a culture, I want you to immediately put put 2 drugs on it. I'm sorry? You can add a second drug, could be Cipro. It could be Levaquin. It could be anything that covers, or it could be a pen. Anything that gives you double pseudomonal coverage. Technically, pseudomonal is such a bad drug, that you're a bad bug, that if you think it's causing another problem, you can get 2 antibiotics for it. Okay? We don't use Zyvox or the Nalzavir until we see VRE, vancomycin-resistant enterococcus. Otherwise, we don't use it. It's too expensive, and also gives you thrombocytopenia long term. That's why we can't use it also for osteo.
What is Phenom?
Carbapenems. So Etapenem. So when you think, the minute ESBL gets mentioned, put that sucker on board. It's a great one to cover the belly. If the belly, what else are we going to cover the belly with? Always add flagyl. Okay, typically flagyl for anaerobes below the diaphragm, Vanco or the other medications, some kind of penicillins for above the diaphragm. Okay? So real simple. If you think the patient is naive, they're not toxic, they're coming from the outpatient world, etc., levo once a day, doxy twice a day, the acetoacetate. You're covered. Okay? What's the BMP marker of CHF? What's the equivalent for pneumonia here? Procalcitonin. So that's another one. If we do a procalcitonin, and the procalcitonin is relatively low, that makes a patient actually better. Listen, we could probably teach you PO. So maybe I'll give you the IV, admit you for 23 hours, watch your white count come down, your fever, you get better, and then I'll send you home on PO antibiotics. And that's the nice thing about these antibiotics. Levo, doxy, are the same IV as PO. And they're once a day, especially the levo. So compliance is not an issue. Okay? And then basically what you're facing in the hospital to start with, because you cannot afford to miss, is Vanco, for in-hospital acquired Vanco, cefepime, or levo has the same coverage too. Plus it has the atypicals. Okay? And all of a sudden, I can also put these together because if I'm worried too much about Pseudomonas. This gives me extra pneumococcal, extra gram-negative. It has atypical coverage. Early on, I cannot afford to miss, so we're going to be broad. And then as we get back information, we may cut down the antibiotics to be more appropriate, less toxic. But we cannot afford to put people on the wrong antibiotic. And what else? What is so important about door to heal time? If somebody comes in with an infection, including a pneumonia, if you don't get the appropriate antibiotics on them within 6 hours, it's like you gave them the wrong antibiotic, it's like you didn't give an antibiotic, the mortality doesn't change. Technically, it should be before 4 hours. And if you do it at 1 hour, that patient does better than the one at 2, 3, 4, but the maximum is 6 hours. So if you don't do this, you're not choosing the right antibiotic, then mortality is exactly the same. And now we're not even talking about the outpatient discharge, pneumococcal vaccine, especially now with the Pneumovax 23 available. Now they get both of them. Okay? Are they also look for, are they splenic? Are they predisposed to encapsulated organisms? Are they young with the meningococcal vaccine? Do they have a work exposure? Which work exposure you have to get into, especially when there's a big cough involved in the pneumonia. In fact, we call it all, the old way was called walking pneumonia. Mycoplasma, right? Well, what about birds? I got called as the third consult one time at Mount Sinai, was when we were training, and nobody had, they couldn't get to this guy's case. And finally, I was the only one that asked him, asked in Spanish, dude, what do you do? Oh, my husband likes the birds, and he cares about them more than he cares about me, and he's always closing them down. The guy had classic ornithoses. The titers were off, but nobody asked them. And then on top of that, what else were you supposed to order? What are you allergic to in a bird fanciers disease? It's not the bacteria, it's the protein. You get an allergic response to it, and you actually get a fibrotic picture, if not an acute picture, especially after, what would you expect for an acute picture? Right after he goes down the cave, there's all the shits at the bottom, that's all the protein. When do birds urinate?
Never.
Through their poop, that's why it's that little drop wet bottom. That's why in chickens the same thing. In Cuba, we were told that children are allowed to speak when chickens urinate. Since chickens never urinate, you get the point, right? Once we get back our cultures, etc., calm down.
I have a
Okay?
question.
Yes.
What are the benefits of legal and moxifloxacin?
Never use Moxie. They have basically the same coverage, but probably more side effects. And Moxie definitely is going to give you QT prolongation. Okay, Moxie and QT prolongation, same coverage. Levo does better. Now, Levo and Moxie, what are the side effects of the quinolones?
Resistance?
Well, to a certain point. In fact, if you see the more Levaquin used, the most quinolone used in the hospital, the more C. diff we see. It almost correlates. So yeah, you make a good point. Well, what are they, right now? What is going to be the hot thing? And they're going to change the question on you now.
Neuropathy?
So now it's tendinopathy, ruptured tendons, Achilles tendons. Now it's a neuropathy. So very similar to diabetes. So now you're going to get a diabetic on Levaquin. You need to be aware of that. Okay? QT prolongation. So new side effects. Any questions on choosing the antibiotics?
This is a question. What does it say up top on the right side? OH home? Nursing.
Oh, yeah, well, they came from, if you came from a nursing home, if you came from a place that antibiotics are being used, technically, you're a hospital, or a healthcare, so you gotta go to the heavy side.
If I walk into a room and I see patients on vancomycin and Zos and I assume that's septic,
Yeah, I
that's
mean,
the only reason to do
why
that.
would you use those antibiotics if you're not, antibiotics are used for infection. Now, what I want you to consider is, Piptazo and all these other medications now may have to be given continuously. They may not work every Q6 or every 4 hours. So things are constantly changing. We need to, that's the stuff that we need to keep up with. Because the guidelines change and we're already behind it. I already showed you that you're getting ultrasounds on your tests. What does that tell you? That you should be doing ultrasounds. That's the future. I can come in with an ultrasound and forget about the x-ray. I can look for pneumonia better than I can in an x-ray. If I know what I'm looking for. In fact, this should be standard training by the time you guys apply for a residency. You're about a year away, year and a half. Okay? So as far as antibiotics, know the classes. And then within the classes, know the difference. For instance, Levaquin and Cipro, 2 quinolones, different generations. Cipro is urine only, and not just any UTI. You're thinking of complicated UTI. Okay? The only time you use Cipro IV systemically is if it's the second drug for Pseudomonas. Otherwise, you go with Levaquin. Levaquin is considered a respiratory quinolone. It covers pneumonia, atypicals, and the problem with Cipro was, we were never told, but day one since Cipro came out, the weakest antibiotic against a bug, against pneumococcus, of all things, the most common pneumococcal bug for pneumonia, had the weakest coverage of Cipro. So we kind of mistreated for a long time. We didn't know this, we know this because of experience.